Hello everyone, I am Dr. Prashant, and in this presentation we will talk about chronic myeloid leukemia. Chronic myeloid leukemia is a clonal hematopoietic stem cell disorder resulting in overproduction of myeloid cells due to excessive proliferation and reduced apoptosis. The molecular pathogenesis of chronic myeloid leukemia revolves around chromosome 9 and 22. This is the schematic diagram of chromosome 22. The black-colored structure delineates the breakpoint cluster region on chromosome 22. This is also known as BCR. This is the schematic diagram of chromosome 9. Shown in red is the Abelson oncogene, which is designated ABL. In chronic myeloid leukemia, there is translocation between these two segments, that is, the breakpoint cluster region on 22 and the Abelson oncogene region on chromosome 9. Translocation between these two structures on chromosome 9 and 22 is key to the molecular pathogenesis of chronic myeloid leukemia. This results in formation of an oncoprotein called BCR-ABL. Formation of this BCR-ABL oncoprotein results in uncontrolled kinase activity, which results in uncontrolled proliferation and reduced apoptosis. The clinical features of chronic myeloid leukemia may be classified into clinical features of the chronic phase, accelerated phase, or the blastic phase. The clinical features of the chronic phase include the patient may be asymptomatic. In symptomatic patients, however, there may be fatigue, weight loss, early satiety, and left upper quadrant pain. Uncommon symptoms of chronic phase include bleeding, thrombosis, gouty arthritis due to hyperuricemia, and priapism. Other uncommon symptoms include retinal hemorrhages, upper GI ulceration, leukostatic symptoms such as confusion, dyspnea, and drowsiness may also be present. The signs of chronic phase include splenomegaly, which is the most consistent physical sign and is present in 30 to 50% of the cases. There may also be hepatomegaly, lymphadenopathy, and infiltration of the skin. Lymphadenopathy and infiltration of the skin is uncommon and generally indicates an accelerated phase. The clinical features of accelerated and blastic phase chronic myeloid leukemia include more difficult to control disease, worsening anemia, splenomegaly, and organ infiltration. There may also be constitutional symptoms such as aches, fever, malaise, and weight loss. The diagnosis of chronic myeloid leukemia consists of a WBC count more than 30,000 per microliter. It may be as high as 300,000 per microliter. Basophils are less than 20% in the peripheral blood in the chronic phase. Thrombocytosis is common and may exceed 1 million platelets per microliter. Mild normocytic or normochromic anemia may be present. Leukocyte alkaline phosphatase may also be used, and polymerase chain reaction and fluorescent in situ hybridization is used to diagnose and monitor therapy, as we will discuss later. The World Health Organization criteria for chronic myeloid leukemia includes a peripheral blood leukocytosis with no significant dysplasia, with promyelocytes, metamyelocytes, and myelocytes more than 10% of the WBC count, blasts less than 2% of the WBC count, monocytes less than 3% of the WBC count, with a hypercellular bone marrow, all in the background of less than 10% blasts on the bone marrow. The definitions of accelerated phase has been given by the MD Anderson Cancer Center, International Bone Marrow Transplant Registry, and the World Health Organization. We will now look at a comparative account of these three institutions defining these parameters: the blasts, myelocytes and promyelocytes, basophils, platelets, cytogenetics, WBCs, and others. We will now look at the definition based on these three organizations for the parameters as described on the left. The MD Anderson Cancer Center says that a blast number of 15 to 29 is the accelerated phase. The International Bone Marrow Transplant Registry says 10 to 29, and World Health Organization says 10 to 19% blasts. Similarly, more than 30% blasts plus promyelocytes according to MD Anderson Cancer Center, more than 20 according to IBM-TR, and this parameter is not included in the WHO definition. Percentage of basophils is more than 20% according to MD Anderson Cancer Center, whereas it is more than 20% basophils plus eosinophils according to the IBMTR. Basophils is again clocked at 20% for WHO definition. The platelet count for the three institutions is as described. Clonal evolution, according to MD Anderson Cancer Center and the bone marrow transplant registry, cytogenetics is not recommended by WHO at the time of diagnosis. A WBC count is not applicable for the diagnosis of accelerated phase, according to the MD Anderson Cancer Center. However, the International Bone Marrow Transplant Registry keeps it as a doubling time of less than 5 days. Unresponsive anemia is part of the International Bone Marrow Transplant Registry, whereas it is not part of the diagnostic criteria for accelerated phase in the other two institutions. Increasing splenomegaly is also a diagnostic criteria according to International Bone Marrow Transplant Registry, and presence of chloroma and myelofibrosis or megakaryocytic proliferation may also indicate accelerated phase according to the International Bone Marrow Transplant Registry and World Health Organization respectively. The definition of blastic phase is more straightforward, with 30% or more blasts or extramedullary disease, according to the first two organizations. The World Health Organization defines blastic phase as more than 20% blasts. Let's discuss the diagnostic and monitoring procedures in chronic myeloid leukemia. We can either use a routine cytogenetic analysis or fluorescent in situ hybridization or FISH procedure. Therefore, there are 4 headings which we need to remember: partial cytogenetic response, complete cytogenetic response, major molecular response, and complete molecular response. A mnemonic to remember this is parties can make champions, with CC with the first 2 and M with the later 2. A partial cytogenetic response is defined as 35% less Philadelphia positive chromosomes at metaphase. This correlates with a BCR-ABL transcript of 10% or less. A complete cytogenetic response is defined as absent pH positive chromosomes at metaphase, and this correlates with a BCR-ABL transcript of less than 1%. A major molecular response cannot be studied using cytogenetics and is defined as a BCR-ABL transcript of less than 0.1%. A complete molecular response is defined as a BCR-ABL transcript of less than 0.0032%. The management of chronic myeloid leukemia has undergone a dramatic change since the early 1990s. Initially, our options were interferon alpha and allogeneic stem cell transplant. However, with the introduction of tyrosine kinase inhibitors, there has been a revolution in the management of chronic myeloid leukemia. The tyrosine kinase inhibitors for chronic myeloid leukemia include imatinib, which is the first-line tyrosine kinase inhibitor and can cause periorbital or leg edema as an adverse drug effect. It is given at a dose of 400 milligrams per day. The second drug is nilotinib, which is approved for the use after imatinib failure and can cause myelosuppression as a side effect and is given at a dose of 400 milligram twice a day. Dasatinib is the third tyrosine kinase inhibitor, which is a multi-targeted kinase inhibitor in that it inhibits BCR-ABL, SRC, c-KIT, and PDGFR. The adverse drug effects include pleural effusion and long QT on the ECG and is given at a dose of 100 milligrams per day. The fourth tyrosine kinase inhibitor is bosutinib, which is a dual SRC-ABL inhibitor and is to be used after imatinib has failed. The adverse drug reaction for bosutinib includes diarrhea and rash and is given at a dose of 500 milligrams once a day. The last tyrosine kinase inhibitor is ponatinib, which is specific for the T315I mutation. Let us now discuss a stepwise approach to chronic myeloid leukemia. After starting imatinib, nilotinib, or dasatinib, we have to look for a major cytogenetic response at 3 to 6 months, and BCR-ABL transcripts must be less than 10% at 3 to 6 months. We must also look for a complete cytogenetic response at 12 months, which is defined as absent pH-positive chromosomes at metaphase, or a BCR-ABL transcript level of less than 1% at the end of 1 year of oral tyrosine kinase inhibitor treatment. If this goal is achieved, then we can continue with the medication. If not, and the patient is in chronic phase, then we can consider dasatinib, nilotinib, bosutinib, and ponatinib. At this point, a decision must be made for consideration of the patient for a hematopoietic stem cell transplant, after which the patient can undergo the procedure. If the patient is in accelerated or blastic phase, then the patient may be given tyrosine kinase inhibitors temporarily, followed by allogeneic stem cell transplantation as definitive management. That's it for our presentation on chronic myeloid leukemia. Thanks for watching, and we will see you in the next video.